Hey guys, it's Ryan. I'm back. Getting back to informant number two, he basically focused on EMS as kind of having that ability to go into patients' homes, see some of the chronic illnesses and some of the reasons why they might have chronic illnesses, whether it's utility outages due to late payments, whether it's a low socioeconomic status that prevents them from being able to have access to the resources needed. And he thinks a lot of this kind of results in abuse of the EMS system where the patients just don't know what to do. So they end up calling 911 and getting transported to the ED when that might not be the best case. He does reference that there was a significant homeless population that street medicine program has really helped with managing, especially managing homeless patients that have CHF, managing homeless patients with diabetes, etc., and really cite a lot of the benefits of being in the city that has an aggressive local health department versus the other surrounding municipalities within the county that don't and that rely on the state health department. Connection to heart failure patients. Informant number one really talked a lot about how the patients are supportive and trusting of local emergency services, and that EMS really understands and kind of knows where the heart failure patients are because they see them so often, and that really ties back into trying to reduce ED readmissions as much as possible. Informant number two talked about some of the environmental causes that EMS sees that potentially cause an exacerbation of a patient's conditions. I really think that EMS is uniquely positioned to help with this community because of their existing partnerships with physicians. They operate in a system that allows them to provide interventions in the field already. And he thinks that because they are frequently in the home, they can address some of those issues in the home or in the environment that we talked about earlier that might impact the patient and their treatment regimen compliance. 3 community diagnoses we talked about. Adult population of Lehigh County is at increased risk of heart disease, as evidenced by the persistence of heart disease as a leading chronic illness and cause of death within the county. Number 2 is affordable and convenient access to medical care throughout the county can differ based on each municipality within the county, thus causing a potential healthcare disparity, as evidenced by information obtained through the windshield surveys. And then number 3, adults in Lehigh County are potentially at increased risk for cardiovascular disease, including heart failure, as evidenced by the higher prevalence of smoking rates in the county when compared to the national average, as well as that of the neighboring Northampton County. So we selected the first one, heart failure, or the adult heart failure population of Lehigh County is at increased risk of heart disease, as evidenced by persistent presence of heart disease as a leading chronic illness and cause of death within the county. The goal, to provide some sort of evidence-based educational plan to the community paramedicine providers, introducing them to high-intensity home visits, how to prevent readmission, improve treatment regimen, improve the quality of life for this population, as well as to try to have the population understand and be educated more about their disease and their symptomology. Feasible interventions. Overarching intervention is going to be really integration of post-discharge and wellness visits by the mobile integrated healthcare paramedics, focusing back on this multifaceted, collaborative, high-intensity home visit program with person-to-person contacts being shown to be most successful in prevention of 30-day readmission. So basically, once they get discharged, have community paramedics see them, have them see them pretty frequently. I worked with a program that was already doing this as a feasibility study, and the goal was to integrate some education to the patients through the community paramedicine providers related to patient symptoms to hopefully prevent them from maybe erroneously calling 911 when maybe calling their outpatient doctor was a better choice. Measurable plan objectives, just what I talked about, development of an educational presentation introducing the heart failure patients and the existing body knowledge around high-intensity home visits, as well as that zone tool we talked about earlier. A secondary objective, which we worked a little bit on, was identifying project scope and implementation timeline for the integration of a EMR kind of bridge between community paramedicine documentation and the primary EMR for outpatient and inpatient care in the region. That one actually was unable to be done to its fullest extent simply because the health network decided to go live with Epic and all the IT resources got dumped into there. Detailed plan for intervention or project, creating a presentation for EMS providers related to the advanced assessment and care and home care of heart failure patients, and then having that collaborative presentation addressing other interventions, current knowledge, education, etc. Potential resources we need: human capital to ensure the education is attended and patient education is implemented. That was not a problem. IT resources from health systems, that's where we ran a little bit of difficulty with that secondary objective. And then leveraging those existing resources from cardiology, the established and trained community paramedics from that beta test feasibility study, and process flows for clinical care, all which were not a problem to get buy-in. Barriers and challenges: funding through IT and IT kind of support unfortunately, and then of course IT security network approvals, which were kind of where we got stuck just because of a lack of resources that were available. Team members: cardiology physicians, EMS medical directors, emergency department directors, cardiology program directors, administrators of participating EMS services, and the IT subject matter experts, all but the latter being well on board and supportive of the program. Key stakeholders we identified: heart failure patients in the community. Obviously, the patient themselves has to be the primary stakeholder. They have to have buy-in into the program, into having the community paramedicine providers come into their homes. The EMS providers themselves, the administrators, community paramedicine providers, cardiology providers, etc. So really kind of in wrapping up, here are my references, and some of the future goals or items that we really suggest would be to have that greater body of knowledge, to do some additional research focused on community paramedicine. As we found with a lot of literature reviews, they all are kind of pleading for a randomized controlled trial to really see what the efficacy of it is, and to see if it could be something that could potentially save lives, decrease mortality, morbidity, and decrease readmission rates. Thank you.